guys, welcome back to the channel. I'm here today again with Dr Kishan.
Hello, hi.
And we are here today to talk about menopause.
Shall we start with a downer?
Yes, why not?
So did you know that all mammals, apart from whales and human beings, the females die after menopause?
What a great fact.
Did you know that?
How lovely.
So we're not here to let that happen, and in fact, our strategy is really to maximise the health benefits for post-menopausal women.
Yes.
So yeah.
I do not want to die at 45.
You can't. She's not allowed to die.
No, I'm not allowed.
She's too expensive.
You
Look
need
at her.
me. So tell us about menopause. Why is it so horrible?
The thing is with women, women are extremely complicated in terms of anatomy, psychology. But yeah, if we focus on hormones, women have like a really, really sensitive interplay of hormones throughout their reproductive years. Estrogen and progesterone are made in sort of delicate rhythms throughout the reproductive cycle, throughout the menstrual cycle. And then there comes a time where production of these hormones abruptly starts to stop. And there can be sort of a time lag. There can be about 5 to 10 years where the hormones produced from the ovaries are gradually declining, but decline they do, and there's a real sort of sharp drop-off in how most women experience symptoms of this decline in the hormones.
So why don't you tell us a bit about, your usual symptoms that you're going to see?
Okay, so a lot of it is poor sleep. A lot of my patients talk about mood problems, so they'll just say that they start to feel more irritable. They don't feel like themselves anymore. That is number one complaint, actually. They don't feel like themselves anymore.
Brain fog.
Brain fog, yes, definitely that's there. I tend to find that's not as much as the whole, I just don't feel like who I was a few years ago. So that, and it's really hard to put your finger on something like that as well. So that's the number one, I'd say, psychological symptoms. Everyone is really aware of the vasomotor symptoms, which are the hot flashes, the feeling sweaty and really hot, particularly at night. So people will wake up in the middle of the night with these symptoms, and then they'll find it difficult to go back to sleep. And that just adds to the irritation, the irritability, the poor mood that people experience in post-menopause as well. And other symptoms as well include difficulty losing weight, breast tenderness, and also lack of libido. Memory issues can occur as well, and of course, as you said, that fogginess of thinking. People really do comment when they come to see us for aesthetic treatments about how their skin has changed.
True.
And how their hair quality has changed.
It's
even
very quick, isn't it?
So I don't know if you notice, women talk about going to their hairdressers when they're pregnant, and their hairdresser can tell with the quality of their hair that they're pregnant, even before sometimes they do, and that's because there's a drastic rise in the hormonal levels. Similarly, when the hormone levels deplete, the hair starts to lose its healthy quality, its hydration, and so that's a very external sign of hormonal imbalance, but that's definitely one that we see quite a lot of.
Something that I often hear in the clinic is, I've got all these physical symptoms, I'm probably not looking as I used to look, I want to take hormones, but I'm scared. I'm scared about the potential side effects of that.
Sure. And I think, when patients ask us that question, they are looking for that reassurance, almost for us to give them the go-ahead. And that's where we come in as medical practitioners. We are completely risk averse. We take our patients' health very seriously, as you know. So we do testing, and we ensure that you haven't got a medical history or a sort of a hormonal assessment that would mean that you couldn't take hormones. So everything would be a considered approach, and that's why every patient is unique. But essentially, most patients can take hormones.
And that's why you're doing the testing, for example, to have a look at their estrogen metabolism. Yeah.
So we do take this super seriously, and that's why our menopausal patients who want to start hormones have to have a minimum of 3 tests, even before they have anything done with us. So that would be a pelvic ultrasound, that would be a mammogram, and that would be a cervical smear. And there's certain situations where we might not need one of those tests, but on the whole, we need those as a baseline before we start prescribing any hormones.
And who would you not give hormones to?
So for patients who've had breast cancer or treatment for breast cancer, and within the last 5 years, that's certainly one section of our patient population that we couldn't treat with hormones. We're looking to provide hormones for general health. We're not endocrinologists, we're not gynecologists, and patients with disease states, we'll refer you on to the right clinician for that. There's always someone who we can't treat, but we've got the right doctor for that as well.
So why don't you tell us a little bit about the testing that someone would need to have?
Sure. First of all, it would be a blood spot test or a blood test in clinic, and where we would look at the levels of hormones that have been used by your body and that would be left in your venous sample. And from that we can extrapolate, and we'll have a good idea of where you are hormonally at one given point in time. And that's the issue. That's at one given point in time. So as a backup, and to give us a much more comprehensive idea of how your hormonal health is, we also do a urine spot test and a saliva test as well, because those will give a much more complete hormonal assessment.
And what are you looking for in the urine, for example?
So we're looking at what happens to the hormones. We're looking at what happens to progesterone, what happens to estrogen, and that's really key. So you still, even in menopause, you continue to make small amounts of progesterone and estrogen. And we want to know, what is your body doing with that estrogen? Because, believe it or not, it can turn into a metabolite which isn't healthy. And then we want to direct your metabolism, or help your metabolism with supplements and with diet, so that we maintain you in a much better, healthier pathway of estrogen.
So it's possible to change the way that your estrogen is being metabolized and take it from one of the bad estrogens,
exactly,
and make it so that it goes towards one of the good estrogens.
It's possible, and the responsibility for us is to retest and make sure that you are actually handling the estrogen well, and that you're actually detoxing from it correctly.
Can you just maybe extrapolate a bit more about that pathway?
So we've got 3 estrogens that are made: estrone, which is E1, estradiol, which is E2, and E3, which is estriol. Estrone is very, very estrogenic. It binds to the estrogen receptors. So for people who don't know what hormones are, it's a chemical messenger that travels from one site in your body to another, and it latches on to receptors on that tissue where it has a wonderful or a not so wonderful effect. So with estrone, E1, that has a very powerful effect on the receptors of your body. Estradiol has a moderate effect on your receptors, but estradiol is the hormone that is the most beneficial in terms of preventing the symptoms of menopause. Also, it prevents cardiovascular ill health, and it prevents osteoporosis as well. It also contributes to feeling sexy again, preventing libido issues, and can also normalize weight issues as well. So that's estradiol, that's E2. Lastly, we've got estriol, which is the most weak of the estrogens. So it binds to the receptors, but its effect is much gentler, much softer. And it's used for other reasons, though, by hormonal doctors. It's often used for patients who've got chronic vaginal dryness or thinning of the vaginal mucosa. So that's where we can really use that to benefit.
Are you using that as a topical?
That would be a topical,
Mm-hmm.
yeah.
And what would you be using to try to make sure that the pathway being followed is a good one?
Sure. So, you know me, it's all about the holistic program if we can. So we've got things like crucifers, whole foods diet, flaxseed, things that actually promote the healthier pathway, which is the 2-hydroxy estrone pathway. Once we've done the whole foods approach, we'd also use things like supplements, like DIM and calcium glucarate, to improve estrogen pathways and estrogen detoxification as well.
Mm-hmm. And any other hormones that you would be looking at replacing?
Okay, so that's a big list there. So we've got estrogen, progesterone. Testosterone is a really important hormone for women, as is progesterone. So those are probably my 2 major ones before we look at anything else. Testosterone is very important for libido and also for weight stabilization, for preventing muscle loss, which is a big issue as we get older. and also topically it prevents vaginal atrophy and vaginal incontinence as well. Progesterone is really vital actually as a counterpart to balancing the effects of estrogen, and you also need it whether or not you've got a uterus or not. So there are some some doctors who believe that progesterone is unnecessary if you've had a uterine hysterectomy. So if you haven't got a uterus, they believe that you don't need progesterone. And I don't believe that, and we don't believe that, because we know we've got progesterone receptors throughout the body, and it's also very helpful in preventing breast cancer.
So there's some controversy about whether one should have a topical estrogen or oral.
The biggest study which relates to hormonal health and supplementation of with HRT is the Women's Health Initiative, which was stopped in 2002. They were using synthetic hormones, and they discovered a really some negative effects of using HRT in postmenopausal women. The results of that study have been extrapolated to body identical hormones as well, which is quite incorrect in my opinion. But essentially, what the current practice is we give estrogen as a topical gel or a patch or a cream. We give progesterone by mouth, and testosterone also we give as a topical cream or gel. It's a bit controversial, but in America, often the favoured route of giving estrogen is by mouth, and that's because the first pass metabolism of estradiol in the liver creates some esters which help with cardiovascular disease and prevent atheroma formation in the coronary circulation. There's all very high tech, but essentially there's different ways to give estrogen, different ways to give these hormones, and it has to be really tailor-made to our patient. You can even give some of these as a lozenge or as a sublingual triturate, they call it, or as a sublingual drop. In America, they give it as a pellet, as injections. So there's many ways to skin a cat. We are much more safe here, I think, and we try to be more safe here. We try to use as much evidence to back up as what we're doing.
So cutting to the chase, are you giving it orally?
Both.
Okay.
Honestly, yeah. It really depends. It also depends on what our results show from your urinalysis and your serum testing.
Can you just tell them how great my estrogen metabolism is? Please?
Hers is pretty, like it's textbook. Yeah. She's safe. She's
textbook.
okay.
Textbook.
Yeah.
And what about the testosterone vaginally? Can we just talk about that?
Sure. So testosterone does have some side effects, some complications, which we know it can cause a little bit more hair growth, particularly on the body, and it has been reported to cause some hair loss on the scalp and some acne as well. Now these complications are basically if you're susceptible to them, and if stopping the testosterone basically allows the complications to gradually disappear as well. However, I find that by giving the testosterone on the groin or intravaginally prevents incontinence. It also helps with the mucosal health of the vagina as well. And given in really, really low doses, it seems to have a really good effect systemically as well.
Okay.
I don't want to talk about libido with this one because it's just dirty.
He doesn't want to talk about libido.
Do not leave that in. I'll say something else. Okay, fine. And vaginally gives some help with libido.
There's other stuff as well that you can use. It doesn't end there.
So DHEA it's almost like a mother hormone because it produces estrogen and testosterone as well. And that has also been linked to longevity and general good health. So DHEA is another supplemented hormone that we can consider for you if your levels are low. And we sort of aim for youth levels. So we're not looking to replace DHEA for a 50-year-old or a 60-year-old or a 70-year-old. We're looking to replace levels for a 30-year-old or a 40-year-old so that you feel better. The other hormones that we can consider are Pregnanolone, which has been shown to give a benefit for people who've got word finding issues with memory. So if you're sort of sitting there sometimes thinking, oh, it's on the tip of my tongue, it's really annoying me, and that's happening to you frequently, Pregnanolone, which is a really high up in the hormonal cascade, that's a very good hormone to consider supplementing you with. So we would trial that for you and see if that helps. Also melatonin. Melatonin is a really important hormone for sleep and for well-being. And taken at night, it can really help achieve some balance, particularly if we've got other issues with sleep or chronic stress.
So, talking about myself again, I take the Pregnanolone right now, which I think actually has helped with that.
So what's it helped you with?
Word finding.
Right.
Yeah.
Even at your age?
Yeah.
So the menopausal women who come to me talk about it happening sort of 5 years after menopause and really having difficulties with this particular problem. But I mean, it just shows you everyone's a snowflake.
What else? Melatonin, incredible. Really.
Good sleep.
Yeah, fantastic.
You can have hormone holidays with these treatments. So you don't, if you have, for example, an injection, you have that effect with you for at least a couple of weeks. And then, as I've said in other videos, is that the effect can actually start to decline quite rapidly. So you're left for a period of a few weeks without the beneficial effect of it. Whereas if you have a topical treatment that you can apply every day and that we know it's active for several hours, and maybe even for the rest of the day in its entirety, you've got a degree of control as a patient as well.
Ooh, let's also talk about the difference between these body identical hormones and the ones that you might get from your GP, for example.
So we generally will use a lot of licensed, branded hormonal medications that you can actually get from your GP as well. And that's what I would sort of say, that's absolutely fine. So if you want to see your GP and have the same hormones prescribed for you, that's fine. I just find that the subtleties of it, the subtleties of prescribing it, are something that we have an intimate experience with, and we've done a lot of training from America and from England, and in Belgium as well. So we've seen how different countries prescribe, different professors prescribe, and I think we've found our own middle ground. I think it's comfortable.
Also, some stuff you just can't get.
You can't. So, for example, testosterone preparations that were available about 2 years ago are no longer available now, due to supply issues or manufacturing issues. So we would have that compounded for you. But in the main, I will say, I prefer to give licensed medications because we've got a wealth of research and evidence-based medicine supporting them.
Maybe let's speak a bit about the difference between those and synthetic hormones.
Sure, absolutely. So it's apples and oranges. I mean, if you're looking at Prem Pro, so we've got Premarin and Provera, which are synthetic estrogen and synthetic progesterone. Now, those in combination were found to have a much higher incidence of breast cancer, venous like clots basically being produced by the body and causing DVT or more serious complications affecting the lungs, and I believe heart attack as well. These synthetic hormones, I don't know of many doctors who still prescribe them. They're still prescribed in America, for example, and I think even British Menopause Society still has a role for recommending some of the synthetic progesterone. I don't. I just find that after the overwhelming evidence that we've seen over the years, there's no need when we've got body identical hormones which are derived synthetically. They're derived from soy or yams or they're derived from the plants, essentially. They're plant-based. So they're not derived from other human beings, but they are body identical, which means that they are identical to the estrogen and the progesterone that you would have been producing in your reproductive years. They exactly fit the receptor on the tissues that they're meant to work on, and therefore they're like old friends meeting, shaking hands, and wonderful things happen, rather than the negative side effects of synthetic hormones.
Can you maybe just give us an example of some synthetic and some body identical hormone names?
Well, synthetic progesterone was called Provera, or norepinephrine. We've got MPA. I can never pronounce it, so it's MPA. And we've got synthetic estrogens, which were derived from pregnant horse urine. So we've got things like Premarin and Prempack, which were prescribed. Yeah, I know because my relatives were given that by their GPs in their menopause years, and we know for a fact that they're much stronger and they have very different effects to bioidentical hormones. Officially, there's a 10-year window beyond which you should not be started on hormone replacement because of the risk in destabilization of your heart health.
So what would you give those patients? Anything?
We can recommend things like DHEA or Pregnanolone, or certainly nutritional support as well. I'll be honest, with patients who are beyond the 10-year window, I think it would still be worthwhile doing a consultation and doing the testing, and then seeing if we've got safer options. For example, progesterone is safe to give, testosterone as well. It's just I would be concerned about the estrogen.
And how long would one have to take these hormones for once you've started them?
It's a personal choice. I mean, I often recommend my patients to have a hormone holiday. So if, for example, they've been having it for several years and they're not feeling the effects so much, that's one thing I've found, is that we get this sort of receptor desensitization. So patients will be applying the hormones or taking them by mouth, and then they find they don't feel as good. So I'll tell them, you know what, have a break. Have a break for as long as you feel necessary, and then come back to the hormones, and that seems to reset everything.
I feel like we could probably talk about this
for
hours.
Me and Sarah have been together at so many courses now for hormones that it's kind of one of those things that we know internally affects you so much and has so many benefits that we're really quite passionate about it.
It's a shame, isn't it, really, that more people don't partake.
I'll be honest, I think it's the future, and it's just that as a society, we are very, very cautious. We're very risk averse. We're obviously, and so are we. But I think it's the future.
Totes. Okay, so next week we're going to talk about perimenopause. Yeah. So see you then.
See you guys. Bye bye.